I'd like to welcome everyone to the IMWG Conference Series for 2019 from Orlando, Florida. This is the one which is dealing with the best of ASH. First of all, I'd like to thank our sponsors for this event, Takeda, Amgen, and Janssen. I'm very pleased to welcome my guests for this conference series. To my left, I'm very pleased to welcome Mateos from the University of Salamanca in Spain.
Hi, Brian.
Pleased for you to be here. And Dr. Joe Mikhael from a couple of different places, translational genomics in Phoenix, Arizona, but we're very pleased that he's also the Chief Medical Officer for the International Myeloma Foundation.
Great to be here, Brian.
Very, very pleased about that. So this evening we have 5 areas for discussion which have all been very actively discussed at this year's ASH. And so I'm going to take you through a step at a time, and we'll get comments about each of these: smoldering myeloma, frontline therapy, the significance of particular ASH testing, the immune therapies, and then some of the more novel therapies and combinations that have been discussed here at ASH this year. And so the first topic is smoldering myeloma, and there really is considerable interest in smoldering myeloma, particularly high-risk smoldering myeloma. And obviously the question is, what exactly is high-risk smoldering myeloma? How do we define that? And then perhaps even more importantly, at this point in time in 2019, 2020, how should it be managed? And so the International Myeloma Working Group has been working really hard in this area and has analyzed over 1,000 patients with high-risk smoldering myeloma to assess the predictive factors. And so we started with one idea which was evaluated by the Mayo Clinic team, looking at what is called the 2-20-20 model, where the serum M component is 2 or greater, the free light ratio greater than 20, and the bone marrow percentage 20%. We have in addition looked at a risk score model where one can take in the exact values that a patient has, and so we can have a different combination of these different factors to achieve a score which can be a high-risk score, or for the lower values, a low-risk score. And from my perspective, actually, the ability to identify a low-risk score is just as important as the high-risk score. Now, the question is, what is the rationale to potentially treat this group of patients? So to treat the disease early, one idea which I know that myself and Mary V are quite committed to is to attempt to achieve a cure. Obviously the downsides to that is that one does not want to cause harm, and one does not want to produce some sort of a negative clonal selection, and so one needs to pay attention to that. It's pretty dramatic right now that there are over 50 trials going on in this space looking at high-risk smoldering myeloma. Those, a selection of those are listed on the left of this slide. I think that similar to the cure trials, there is one with the KRD which does show significant MRD negativity. The others are what one could say is lesser therapy, and they do not have achieving MRD negativity as a goal. And so what are the results using the Caesar trial combination of KRD, transplant, and then consolidation and maintenance? And Mary V, you presented these data that you know very well, and just to emphasize that the response is improving and that the MRD negativity rate is at 62%, something very important to be aware of. And so Mary V also updated the PFS and overall survival data, which are obviously very impressive at this time point, and she can comment more about that in a second. But perhaps rather surprisingly, what was of tremendous interest at this year's ASH was the use of mass spectrometry to evaluate this population of patients. And so mass spectrometry defines molecular mass, and the intensity of the spectrum indicates the amount of the protein. And this is a very precise approach which identifies the protein and does tell you precisely how much is there. So what did the results show? Well, looking at the patients throughout the disease, it was impressive to look at the comparison initially between the SPEP results and the quantitative mass spec. And you can see in each situation, mass spec was more sensitive. If you then look at the comparison with NGF, again, looking for positivity, mass spec was actually more frequently positive. And so looking in a combination of scenarios, one that is particularly interesting, what about the patients who are negative by NGF but have a persistent spike by mass spectrometry? And so a couple of explanations were presented and discussed. Does this mean that there's patchy disease that was not picked up on a bone marrow test? Or maybe there's extramedullary disease? My sense is that there's some emphasis toward the first, that maybe it's more to do with patchy disease. So, thinking about smoldering myeloma, I've listed 4 particular questions here. How do you feel about the criteria? Do we need to do more work? Are we starting to cure some of those patients? And how do you feel about those single agent therapies in comparison right now? And what will be the impact of mass spectrometry?
Excellent topic to start this conference series after ASH meeting. Smoldering definitely is a hot topic to debate. I think that the definition of high risk was much more confusing in the past, because now, as you mentioned, the International Myeloma Working Group has been doing a great effort in order to homogenize, in order to harmonize the definition of high risk. So now I think that the 220 model is worldwide available. Yep. And I think that this is going to be the uniform model every investigator can use in order to identify high-risk smoldering myeloma patients that we know that will have a 50% progression risk of progression to multiple myeloma. Yeah. And concerning if we are going to start to cure some patients, hopefully yes. And in fact, you and I are working on different projects, similar projects. Maybe if we are going to be able to cure some patients with KRD, transplant KRD and Lendex maintenance, you will definitely be able to cure more patients because the approach is similar, but adding the monoclonal antibody daratumumab. Yes. I think that this strategy definitely is encouraging. We need, of course, in our GM-CSAR trial longer follow-up in order to see how the outcome is, but definitely it is possible to offer the cure to some smoldering myeloma patients. Personally, I consider that if we have to choose versus single agent therapy versus combination or much more intensive approach similar to that we do to myeloma patients, personally, I consider that high-risk smoldering is a closer disease to the myeloma. Yes. And this means that maybe the future will be to treat them as multiple myeloma. Yes. And maybe in the upcoming years, the term of smoldering maybe will disappear, I don't know, but high-risk smoldering will be myeloma and low-risk will be MGUS.
Right, exactly. So I think the two of us are on the same page with that. I think that it's a way to look at smoldering is it's just really early myeloma and deserves treatment as myeloma. How do you feel about that?
I think you can make 3, because I think we all agree. You know, even as I explain this to patients, I think of it as, you know, we used to define myeloma once there was true damage to the kidney or the bone or to the blood. And pardon the analogy, but sometimes I think of it as if I'm going for a run and I'm heading towards a cliff, you don't have to wait till I'm falling off the cliff to know I'm in trouble. So we changed the definition of myeloma and drew a line, let's say 50 feet away from the cliff to say if you get this close, you're in trouble. But I think that slim crab criteria that we added to the crab criteria none of us think that's the perfect line.
No.
And
Maybe
I
we
completely agree.
maybe we need a wider crab.
Yeah,
maybe
absolutely.
75 feet from the cliff.
And I think that's what we're doing with that. That risk score is particularly helpful. I mean, I actually
Yeah.
use it in the clinic. I bring it
Yeah.
out and I have the patient look at it, and then we
have
calculate the
an
number
app
together.
that's going to be released soon for that.
That's wonderful. And so I think what will happen is if, let's say, we're 50 feet from the cliff now, maybe we'll move it back to 75 feet from the cliff. And I agree absolutely with you, Marie-V, that those patients between, let's say, the 75 and 50 feet, they're basically myeloma patients.
Yes.
And we should have an early treatment, curative intent approach. My worry is if we go too far back with heavy treatment, we're over-treating people.
Yes,
And I think
that's the,
I agree
that's the
we'll-
delicate balance.
Exactly. I
Yeah.
think we'll likely eliminate the true diagnosis of smoldering myeloma, and I couldn't agree with you more. I think the single agent studies are concerning because they're not really, none of us think that one drug in the way that we
can
have
have a
them can
powerful
really
impact.
change the nature of myeloma.
Absolutely.
What you want people to do is never to run towards the cliff, and that you've got
Right.
to do much earlier.
Right.
And I think that's the way we're moving. As for the mass spectrometry, I actually think with time, as we work out the nuanced details, I think it actually will be extremely helpful because it's a much quicker test, it's a much cheaper test, a more accurate test in general,
Absolutely.
as we're seeing. And the day could come where it will simplify for those of us who have to look at serum protein electrophoresis in the lab. I mean, patients hang on to that one exact number, but
Exactly.
if they saw how we come to that number,
Yeah,
it's not always simple.
Exactly. So maybe back to you, Mary-V. So in the patients who are NGF negative but mass spec positive, I know that one of those patients has actually been the one that has relapsed. Do you see that it might be helpful in that type of a scenario?
Yes, so definitely QIP mass is much more sensitive. And together with your comment, I think that mass is going to optimize the timing point at which we have to do the bone marrow.
Yes.
And this is extremely important, maybe not for physicians, but for patients, because
Yes.
the timing at which we will do the bone marrow in order to see if the minimal residual disease is positive or not is going to be much more accurate.
Absolutely, I agree. So sometimes we do the bone marrow and then it's still positive and you have to repeat it 1 or 2 months later. Yes, exactly.
And concerning patients with the next generation flow negative, mass positive, maybe the bone marrow is patchy and maybe the bone marrow aspiration has been done in a place in which there was not plasma cells. This has not been well evaluated in our gene Cesar trial because all patients were asymptomatic. This means
yes.
that extramedullary disease was not present. So
Right.
definitely this is something in which we have to investigate much more in the symptomatic myeloma setting.
Right. And we have, as we'll go through these areas today, we'll see opportunities where this could be assessed in patients with active myeloma.
Yes, this is something that we are going to do in the upcoming months.
Right.
And I think it speaks to, to conclude this thought, it speaks to the fact that myeloma is difficult to measure with one test. I mean, we're going to learn with PET scans and other things, so many other diseases, there's one sentinel test. Here it's more than one, and there aren't just going to be small exceptions to the rule. We want as many angles on the crime scene as possible to know exactly what's happening.
Absolutely.
But I'm especially pleased that we have a blood test that can be potentially very helpful, and we're not going to talk about it today, but one can also measure the monoclonal plasma cells in the blood, another blood test which can help guide
Less
us.
marrows are good for patients.
Right, there you go.
Absolutely.
So we're going to have to move forward here to discuss frontline therapy, and at this particular ASH, there were a lot of presentations, oral and poster, about frontline therapy, all different types. The key question has really been, what is the story by turning the triplet into a quadruplet with the addition of daratumumab, the monoclonal antibody? And so I'm just going to show a little bit of data. So obviously the starting point, the sort of standard of care, is VRD with an autologous stem cell transplant for those patients based on the IFM study with excellent PFS. With this, we're still waiting to see the impact on survival, and we can maybe talk about that separately. But we also have a very nice study from the Spanish group where the number of cycles of the VRD was extended to 6 using a change in the dose and schedule that allowed that to happen. And so we're certainly focused on the number of cycles of therapy as something to be important and to consider if it can actually be given to the patient. But we're all very excited about all the different quadruplets, and this just shows a set of curves from the daratumumab VTD study versus VTD, the Cassiopeia. And this is interesting because Philippe Moreau presented it looking at MRD, in this case combined with PET-CT. And the interesting thing is that combined negativity of MRD and PET-CT gives you better outcomes, in addition to obviously the added benefit of the daratumumab. And so then we have the update of the Griffin trial, which adds daratumumab to the VRD. And again, very promising results, very early, but obviously with really excellent early response and survival data with Dara VRD. And I think that everyone is optimistic that this will be a very powerful regimen. In addition to that, we have very striking data presented by Luciana Costa looking at an adapted approach but using daratumumab carfilzomib Lamdex, Dara KRD. And you can see here, if you look at the far right curves, a very high percentage of deep responses, both using conventional IMWG criteria, but also different levels of MRD with NGS, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. So very, very impressive depth of response results. And of course, we have the update from your study looking at the addition of daratumumab to VMP. And so we have this situation of several combinations with Dara. And so the question is, with these great results, are we going to just switch over and will some of those become our new standard of care? Or are we still a bit cautious and will we start with triplets? So, Joe, do you want to start with this one?
Sure, yeah. No controversy here.
An easy one?
Yeah, this just lobbed me an easy one. Well, actually, to be honest, I really do think if we start with the transplant-eligible population,
right,
I really think we are going to move towards those quadruplets. The issue there, I almost feel like when we had this conversation at this table a number of years ago, are we going to stick with doublets or go to triplets?
Yes.
There's always the law of diminishing returns. I mean, the data for just VRD is still quite impressive. But there is always a challenging situation where some patients don't do well early on. I think the idea of adding daratumumab to either VRD or KRD primarily, although depending on what's available in different countries, sometimes it's VTD or potentially IRD, I think that's going to happen. I think the Griffin study is likely going to lead to us using a lot of Dara VRD, in particular here in the US, or potentially Dara KRD as we're often using KRD in the high-risk situation. And I think that will be more the standard of care in the not-so-distant future. Partly because adding daratumumab to those two regimens adds benefit without a lot more side effects or toxicity. I think in the transplant-ineligible population, it's going to take us a little bit longer to come to that conclusion. I mean, apart from your study with Dara VMP, we really don't have any other quadruplets in the transplant-ineligible population. And we're seeing a lot of Dara RD and VRD in that situation. And we've tended to favor VRD, as you mentioned here, modified or a little bit lighter.
Right.
You know, there's about 10 different ways to give VRD, but dose reducing a little bit towards a patient's frailty and comorbidities, and particularly in the high-risk patients. And then in the standard risk patients, having a choice of either VRD or Dara RD, I think for at least now remain the standard.
So how do you view this?
Yeah, so I basically agree with Joy, and I think that in the transplant-eligible population, definitely the 3 drug-based combination plus the monoclonal antibody is going to be the standard of care. In fact, when we see this list, it's true that it is possible to add Dara to VTD, a much more cheap regime, but also we can add to KRD, a much more expensive combination. But the good news is that we have excellent data coming from the different combinations. So physicians can be confident choosing either VRD, KRD, VTD, plus the monoclonal antibody. Absolutely. And in the non-transplant eligible population, it depends because we can call honestly for drug-based combination to VMP plus Dara, but honestly I understand that it's not the same that VRD plus Dara, and this is not a real for drug-based combination.
Right.
DVMP has shown benefit in overall survival, and again I think that this is a combination that can be affordable because it
Right.
is not going to be very expensive, and it's definitely useful for the elderly patients. However, it's true that if we go to the Maya study, the median progression-free survival expected for Dara
Yes.
Lendex, and this is just a 3 drug-based combination, is going to be excellent.
Yeah, absolutely.
And the same for VRD, with the possibility of using even VRD light. So definitely I think that even in the elderly population, Dara will be added for sure, and depending on affordability, availability, and so on, it is possible to use VMP if the economical situation is
Right.
not very good, Lendex or even VRD in the future.
Absolutely, yeah. So that it's great that we have these possibilities depending on drug availabilities and the status of the patient, comorbidities, and frailty factors.
But the good news is to have clinical data coming from all combinations.
Yes, yes, exactly. Yes,
And that
yes.
each of the combinations can be modified to that patient's needs.
Yeah.
And I think
Yes.
that's what's important. With
Right.
this idea that there's only one cookbook way of doing VRD or doing KRD or now DVRD, I think this is going to be very helpful that we can make modifications now with
Yeah.
so much more experience where we don't want to overdose nor underdose patients with the principle of leveraging the combination up front and then potentially stepping down a little bit with time once the disease is under better control so that we don't provide too much toxicity. Like when we do VRD, we don't continue the V indefinitely,
Yeah,
but we can
absolutely.
you know, step it down. I typically will step it down to every other week for
Yeah.
a while before discontinuing it.
Yeah.
So maybe a quick question before we move on. Is there a possibility that with these much better combinations, we are looking at maybe autologous stem cell transplant might not be always automatic in the future?
Well, personally, maybe. I think that we need much more data. Definitely, the Forte study conducted by the Italian myeloma group is giving us important data.
Right.
And personally, I consider that minimal residual disease as well as a risk status can potentially drive to not, well, drive the situation in order to avoid the transplant in some
Yes,
patients.
yes.
According to the results of Francesca Gai, maybe patients at standard risk and achieving minimal residual disease negative after a 3 drug-based combination plus the monoclonal antibody maybe do not need the transplant in the first line.
Right.
However, high risk or patients with ISS 2-3, maybe these patients, at least with the data we have today, transplant should be considered the standard of care.
Right, right. Okay, we have to move on, but that was also a topic that came up in several discussions. Where are we with the role of transplant?
And I think that'll be a feature of this conference series
Maybe next
for
year. Yeah,
several years to
yes,
come.
Yeah.
Absolutely, absolutely. All right, so there were some additional presentations looking a little bit more closely this year at the impact of baseline FISH testing. The first is 1Q21, and I guess the realization that this is an important risk factor that we haven't been always incorporating or looking at, and then looking more closely at 1114, which we've up to now at least considered to be a good prognostic factor. And so what did we see presented here? And there are several things interesting here. This is data from China, from Tianjin, where they have a huge database with good FISH testing. And you can see here for both PFS and overall survival, the combination of the presence of the 1Q21 gain and 414 is definitely the most important negative combination. So we do need to be aware of that, and we're looking to assess 1Q plus more routinely. The other observation has been the opposite kind of observation, where if you have translocation 1114, those patients actually seem to do significantly better with autologous stem cell transplant. And it may be, since we looked at that in the French studies, where transplant was frequently used, it may be one of the reasons that we always felt like 1114 was good. But I think without doubt the greatest interest at this meeting was what was the follow-up for the Bellini trial, in which venetoclax was given to patients with BCL2 overexpression in combination. There was a concern, and the study was stopped, as we know, because of increased deaths in the combination arm. However, with the update here in July, the survival outcomes have actually balanced out somewhat, and with more detailed evaluation, what was presented in a very striking way is that certainly for the T1114 population, the combination with bortezomib and dex plus venetoclax is clearly dramatically helpful. The role of the BCL2 is a little bit more complicated because some patients can have overexpression but don't have the 1114. And so you can see also for the non-1114 really that added benefit, you just don't see that. So in this discussion, how do you view the impact of 1Q plus, and obviously do we need to be looking at that more closely and thinking about that as part of our trials? Who wants to comment? You want to talk about
Sure,
that
yeah,
first?
I can start with these two. Yeah, absolutely. I mean, I think you captured it well at the start. I think for a lot of patients who historically we didn't characterize at high risk, but they seem to behave, if you will, as a high-risk patient, many of them are quite likely because of that 1Q. And I think what's interesting about the 1Q compared to some of the other cytogenetic abnormalities we look at, I mean, to a certain degree we see this with P53, but it depends on the degree of the 1Q. The more gain, the more a concern. You know, as we've created even double hit myeloma when there was more than 3
double hit.
But also the partner, well, the cytogenetic abnormalities partner from plus 1Q. We have analyzed our large series of patients included in the Spanish myeloma group, and plus 1Q as isolated abnormality did not impact very much in the prognosis. And the poor prognosis is, as you mentioned, by the addition of another high-risk cytogenetic abnormality. What is very important, because definitely I consider that these patients with plus 1Q plus 414 translocation or other high-risk cytogenetic abnormalities should be treated as high risk.
Yes.
I agree with that.
Very important point.
Absolutely, especially because we do so often see them in combination. I mean, 1Q by itself is actually fairly common if we look for it very carefully.
Common.
That's why the more copies are not as common, or seeing it in combination. So I do think it's reasonable to treat these patients as high risk. And when it comes to 1114, I think we've really learned at this meeting, not just from the results of the Bellini study, there were 2 other presentations looking at using venetoclax in the translocation 1114 population, really demonstrating great response. Even patients who were essentially pentarefractory, meaning they had seen the 5 major drugs, had gone through just about everything, still had a very good response rate to venetoclax and dexamethasone. That was Jonathan Kaufman's paper. And so, although we still think of myeloma as a relatively uniform disease when we start with DVRD or DKRD, maybe high risk, standard risk, there's no doubt that biologically 1114 myeloma is a little bit different and maybe particularly responsive to venetoclax. Although we have to be careful now, obviously in light of the Bellini situation when we use it. But I'd be comfortable using it in that 1114 population with or without bortezomib. To try and control that disease. And we have so many patients that have really benefited from that, even if they haven't used the others. And lastly, we still do transplant these patients for sure, whether it's the transplant effect particularly so, or just giving them appropriate intense therapy. I'm not sure there's something biologically between high-dose melphalan and 1114 that we've really discovered yet. But in general, as we've said before, we haven't quite yet dispense with transplant by any means, it's still the standard of care, but in
Right.
particular in 1114 patient, I would
Right.
offer the transplant pathology.
There was a hope before a year ago that venetoclax with benefit in the combination, it would be rapidly moving into earlier scenarios, for example, even for 1114. But I think my sense is that maybe we need to be a little bit cautious now as we move it into different regimens, perhaps?
Yeah, absolutely. I think that the sub-analysis conducted in the Bellini study are excellent, especially for patients, because we were able to identify how patients with 11-14 translocation benefit in terms of progression-free survival from venetoclax. So this is important because, during this year, in June, July, we were going to waste venetoclax for patients with
Right.
multiple myeloma. So now I agree with you, we have to be cautious. The benefit is there in terms of progression-free survival. There is not any benefit yet in terms of overall survival, but I think that it will be a promising drug to be used in this specific population.
Right.
And concerning the role of transplant in 11-14 translocation, the reason is because patients with 11-14 translocation are more closer to non-Hodgkin lymphoma than to myeloma, in the sense that these patients usually do not present with a very high monoclonal component, much more plasma cell bone marrow infiltration, and this is the reason why transplant works very well in these patients.
A lot of good points there. So very, very good. So there was a lot of discussion of that, and certainly even at the IMWG breakfast, we paid attention to this, where we're talking about incorporating 1Q plus into a revised ISS staging system,
Yes.
and I think we probably need to do that in a systematic way, but based on data. Okay, well, as I say on this slide here, immune therapy really has dominated here at ASH this year, and in each of the three areas that I list, the CAR T therapies, the bispecific T-cell engagers, and then the monoclonal antibody drug conjugate, the GSK belamaf, a lot of interest in the updated data there. Mostly because all three categories are moving forward, and we're expecting that they will have some degree of approval in the near term.
Yeah.
So first of all, for the CAR T, obviously the CAR T therapy, we've been thinking as a possible game changer for the last couple of years or so. This harvesting of the patient's own T cells and the genetic engineering. The concerns have been obviously that it takes time to do that, so that you have to wait for 2-3 weeks, and then the concern about the toxicity, particularly cytokine release syndrome. So there's been a lot of promise, but also some concerns. However, here at ASH, there was I think probably a big sigh of relief, especially from the Janssen company, that the product from the Legend Chinese company had a very successful trial here in the U.S. With a very favorable toxicity profile. You see here that there was one patient who did have some dire complications, but otherwise the profile of the toxicity really quite acceptable. And then, of course, the deep early responses really excellent, and so I would have to say tremendous enthusiasm about that, which was actually reflected by the fact that they did in fact this past week receive a breakthrough status from the FDA. So I think that everyone is kind of feeling this impact of this promising therapy. Now, in addition to that, there were a whole range of CAR T protocols, and it's hard to pick one. But I just thought I'd point out something which is a little bit of a trend, so that the Cartitude came from China. But at this meeting, there was also a second one that comes from China that was presented, which has a safety switch in it. And then there's another one coming along, which is a humanized version. So we're seeing this trend where some of these new innovations in the CAR T space are actually starting off in China, and with some validation that we're seeing. And so it was interesting to see that this IMWG product showed very, very excellent results in 3 different hospitals with excellent responses and with acceptable toxicity. And it was really encouraging to see similar PFS and survival data. And also interesting to me is that they also are starting to look carefully at why is it that some patients are non-responsive or relapsing, and they made this observation, which has not been made before, that it could be linked in with the mTOR pathway. So some very interesting things happening in that arena. But I would say that maybe even more excitement, because people have been hoping to see what would happen with the B-cell engagers, T-cell engagers. And so this is the product from Celgene, and early data showing, again, using this, which is similar to a BiTE. BiTEs come from Amgen. This is basically like a BiTE, but coming from Celgene. And you can see strikingly here that there was a strong dose effect. At the lower doses, not too much benefit, but they have achieved a very effective dose with acceptable toxicity, and so clearly strong interest in that. And so perhaps a different type of excitement about the monoclonal antibody drug conjugate, the GSK product, because it might possibly be the closest to coming to commercial availability. And so obviously 2 or 3 things to point out here. Obviously there's a direct monoclonal antibody against the same BCMA target, but the interesting point here is that it's not so dependent on the BCMA expression, because if you have binding, then with the introduction of the drug into the cell, you have that added cell kill potential, maybe even at lower BCMA expression levels. So a number of areas of interest there. But again, here we have a strong response profile. Maybe slightly lower than the CAR-T and the bispecifics, but very impressive responses and durations of response. The unusual thing about the GSK product is the corneal toxicity, which is definitely going to have to be carefully managed. But it does seem to be manageable and reversible, and so it seems that this will be an issue that we need to be aware of, but something that can be handled. And so, what do we think about all this? We've got 3 groups of agents, all clearly very active in the relapse population. And so how will we look to introduce those for our patients, to sequence them potentially? And in this case, do we see them having a best use maybe earlier in the disease for consolidation, or an earlier relapse situation? And so, Mary V, maybe you want to start first. What do you think about this?
Well, definitely I think that all new immunotherapy strategies you have shown, especially CAR-T and the T-cell engagers, are encouraging, and I would say that even in the future I can envision that they can be complementary.
Yes.
Why? Because the results from CAR-T are spectacular, but it's true that in myeloma, for me the problem is the duration of the response.
Yes.
And the duration of the response is not so long as expected.
Right.
Maybe CAR-T is excellent in order to achieve rapid and deep responses, but we need something to maintain the response.
Right. I agree entirely. If we look at the PFS curves, I showed you a couple there, and there is a continued drop in those curves.
So why not to incorporate the T-cell engagers as part of maintenance after CAR-T?
Absolutely, or even the GSK product.
Or even the GSK. This is a complementary strategy. The results you have shown about the T-cell engager are really comparable to that reported with CAR-Ts.
Yes.
Also rapid and deep responses. We need a longer follow-up in order to see what is the durability, but if the results would be similar, these T-cell engagers would be ideally for patients non-eligible for CAR-Ts.
Right.
Very elderly patients with some comorbidities, poor performance status, or frail by definition. These patients would be candidated to the T-cell engagers or maybe the belamaf madofotin.
Correct.
With the belamaf madofotin, we have, as you said, we have to take careful about the ocular toxicity. And also we have to take care about the thrombocytopenia.
Yes.
Because patients develop thrombocytopenia and usually it takes some weeks, even some months in order to recover it.
Okay.
But definitely I think that the results they showed are promising. I think that all these drugs, all these modalities will be moved earlier on, of course. And we need, of course, more data and more clinical trials in order to know what is the appropriate therapy and at which time, and how are we going to incorporate all these new strategies in the landscape we have just been discussing about quadruple combinations based on VRD or KRD plus Dara.
Right.
How are we going to combine?
Right. Absolutely.
The good thing is we have more options, right? So, and this is what I think
that's
is
the
most
good news
important.
and the bad news.
Yeah, absolutely. We may not know the right order and the sequence, but I think the more the better.
Yeah.
The two things I'd add to this, Brian and Marie-V, one would be, I don't know if anyone really feels that the CAR-T products we're using right now are going to be the final ones we're using.
Yeah,
so we're seeing
this
these,
is a very important
as
point.
I like to say, the next generation
No,
cars,
this
right?
is
We're
the
getting
starting point.
exactly. We're getting better horsepower, and we're
Right.
adding a bigger moonroof, and we're having better features to the car,
Sure,
and I think that's helpful.
One philosophic part to that is, if we're looking for a better car, do we want one where it's used in a decisive way, or one where we're looking for a more prolonged exposure? Are you with me? If it's humanized and might be given. My bias is that we should maybe be looking for that decisive impact.
Agreed.
I
completely agree.
As a new car.
Almost like a potentially with the chance to replace transplant at some point with time, but where it is very intensive. But if these new cars, if you will, can persist longer, and I think of this as the hybrids, right? They can go longer. I know the analogy could be stretched here, but one of the reasons why we think, at least, that the current CAR T-cell strategies aren't lasting in myeloma patients is their T-cells are exhausted. Their T-cells don't have the longevity.
Right. Yeah.
You know, we're taking T-cells that are kind of at the end of their life cycle and expecting them to
so
to
using
go back
cells harvested earlier in the disease, right?
Correct. Or if we have other ways to you know, give those T-cells a bit of the fountain of youth to stay on would be good.
Yeah.
The second point is, I think another very important reason why we want these different options, especially with, you know, belantamab mafodotin and the bispecific agents, is that even if it is that decisive a strategy, CAR T-cell therapy is always going to be difficult to have greater access.
Right.
I mean,
absolutely.
right now,
intrinsically,
we
always,
think exactly maybe 30 to 50% of people who could get a simple autologous stem cell transplant in this country don't get it, because they may live too far away from a transplant center, or there's travel issues or insurance issues, whatever else. You know, CAR T-cell therapy is not exactly like an autologous stem cell transplant, but a lot of similarities.
CAR
cells,
and
so it is a bit of a boutique approach. So
having a fantastic bite could be
correct to sort of take it off the shelf,
Absolutely.
right? So a community oncologist can, you know, literally infuse this drug over an hour, as opposed to going through the weeks of collecting the T cells, manufacturing, waiting for them to come back, reinfusing them. That may be, especially as you mentioned, in a more frail population or one in whom they may not be able to have that intensity. And obviously the time will tell us if there is really a superiority of one over the other. All we can say is we've not seen this kind of deep response rates this late in the disease course with anything else.
Yeah,
so they're all three of them are very impressive.
Right. And I think that the other thing is that we need much more information about, for those patients who are progressing, you know, why is that? What are the mechanisms of resistance? Is it a mechanism that could be overcome by giving more cells, or is it something that where we need to give a different type of therapy to achieve a better outcome, you know?
Agreed.
Or I don't think we know too much about that yet.
Yeah, a maintenance approach after of some sort. Yeah.
This is something that we don't know, but definitely, well, during this, as we had the opportunity to see an abstract using gamma secretase inhibitor in order to upregulate the BCMA expression on the plasma cell, that can be excellent complement to the CAR T when the BCMA expression is low.
lower,
Yeah,
yeah.
exactly. And I think that definitely we are going to have the possibility of to manipulate, to generate new generation of CAR Ts and to complement with all drugs that we have. And maybe even it would be possible to incorporate again in myeloma the checkpoint inhibitors as complementary strategy. We
Yes.
see that one of the mechanisms of escape can be potentially overexpression of PD-1 and PD-L1.
Yeah, it would be good to be able to bring those back into the mix in a safe way.
Exactly.
And I know this is something that's sensitive for you.
Yes.
Yeah.
All right. So in the last area, and there were, again, many abstracts on this topic, oral and posters, and what I've done here is just list some examples of information that we've been looking at. And so tomorrow we're excited. We will hear the presentation for the CANDOR trial, which is obviously daratumumab, Kyprolis dex versus Kyprolis dex, and even in the abstract, we know that obviously the triple therapy is superior. A number of important things about that it does work in lenalidomide exposed and lenalidomide refractory patients, which is an important point. But then we have these other combinations which are potentially usable for a similar patient population. So I'm going to take you through some of the results with these other agents just to look at the response rates and some of the outcomes, just to see what you guys think are the most promising right now. The one on the bottom there, it was a smaller abstract that was presented this year. I don't know if you even saw that. It's a radioisotope I-131 combination, which is linked to a lipid raft target. Quite interesting new approach, which had some new data. So if we just look at some of these survival curves and survival outcomes, again, the Dara Pomdex, very active combination, and is now approved for use, which makes it very helpful. We have carfilzomib Pomdex, also a very active combination, although it's not specifically approved, but is one that can certainly be widely used. Then the new CELMoD, iberdomide, I think for me quite interesting response data, even in, as you can see here, IMID refractory patients. And so even although it's sort of like an IMID, clearly there are some different features to it that make it active, and quite interesting in the Dara Pom refractory. So I'll be interested in how you view those data moving forward, and I think pretty well tolerated. I think makes it helpful for use across the board and in different settings. And so we really do have an amazing number of options, and I just created this table here. When all else fails, we have a number that are currently available, and then all of these different drugs. And quite frankly, I wouldn't like to be the FDA and be trying to decide where I set the bar to approve or not approve all these drugs that are coming forward, very frankly. So how do you look at this space? How do you feel about these different new options, especially for early disease and then for later disease? Maybe you want to start first, Joe.
Yeah, it's impressive, isn't it? I mean, it's almost the same theme we were discussing earlier. The more options, frankly, the better. And you know, we have each of these major drugs and class of drugs, and now we can combine them. You know, my approach, Brian, maybe so often is sometimes even tell patients what I call the 1-2 punch. You know, meaning your first line therapy and your second line therapy or your therapy at relapse. Those two things together are really critical in the long-term survival of a patient. You know, this idea of sort of saving the best for last has really been almost removed from our vocabulary.
Right.
Yeah.
But
So we don't want to overdo
but still
it.
needs to be emphasized.
Yeah.
Oh, absolutely.
It's
And I think that's important. And I think some of the data you just showed really helps us with that. So if we're not quite on the cusp or not quite there right now that a lot of patients are getting Dara VRD or Dara KRD. So if the average patient today is still getting a VRD or maybe a KRD-like regimen, transplant or not, lenalidomide maintenance, we want to think very strategically at that first relapse that we want to give them something very potent. And I think that's where candor comes in, the late-breaking abstract we'll hear about tomorrow. The idea of we definitely want to use a new class of drug with daratumumab, and we can combine it with different things. We've been combining with pomalidomide right now, but I think there is an attraction to combine it with carfilzomib as well. Even though we can overcome lenalidomide resistance with POM, you know, there are a lot of patients I think who could really benefit from Dara-Car. And that's the nice thing about having those options that you listed.
Right.
In one patient, we might determine that Dara-Pomdex is better. Another patient, Dara-Cardex may be better, like in the candor regimen.
Right.
And so that principle of using really the best we have early on, I think, remains very important, and this facilitates some of that.
Right. And so one aspect of that with the candor combo is that you have Dara and then you have Kyprolis. Now, the Dara is not sub-Q. And in the study, the Kyprolis is two doses.
Twice a week, yeah, but this is because it's a registration study, and the control arm has to be carfil, so maybe 56 milligrams per square meter twice weekly. But I think that after the approval of this combination, people is going to switch to carfil, so maybe just once weekly, because it's equally effective and definitely much more convenient for the patient. So I agree with you, although I would like to challenge a bit.
It's about time we have some controversy.
Yes,
right.
Challenge
because,
Joe, yes.
You said that, okay, after almost all patients are going to be Len refractory right now after the first line of therapy, and you would choose KD Dara, Pomdex Dara, or even KPD. What about the BCMA monoclonal antibodies or even the CAR-Ts for these patients in first relapse? Do you see
it's not much controversy because I agree with you. I think part of the challenge is just when they're available, absolutely. I think that will be another approach. But I think the concept of bringing in a different mechanism of action and a very potent drug, you know, I think daratumumab and carfilzomib have proven themselves. These ones are soon on the cusp. But you're right, it will make us start to think that I would have almost thought of it as kind of the next round. So let's pretend we're a year in advance, we've shuttled ahead in time, and now we're using DVRD or DKRD up front. Then you're going to be saying, okay, at first relapse, do I want to use a BCMA product?
Absolutely.
Do I want to use one of those? So in your strategy, I completely agree. I'm just not quite sure that the BCMA products that we've been using are quite ready for first relapse in a broad sense. Absolutely, they should be evaluated in trials.
Yeah,
and in fact, some of the things that you noted, Brian, with many of the Chinese CAR T-cell trials, because of access in the country, many of those trials are actually testing CAR T-cell in the U.S. market was typically first or second relapse because they haven't seen carfilzomib, they haven't seen daratumumab.
Absolutely.
So it's proving the principle in a different geographical region.
Right, but the other thing that is true for them is that actually it's a very efficient and cost-effective option because you have a decisive therapy, and frankly, some of these combinations are very expensive, and then you need to keep taking them. And so there are a number of things that...
you sound like the transplant argument, right? Which always was, you know, it's a little bit more upfront, but then it's a one-time treatment, and there isn't that ongoing maintenance. And hopefully if CAR-T can bring us to the point where we can stop treatment. You know, for many of my patients who have gone through our CAR-T cell trials, and, you know, this isn't always in every patient, but many of our patients, not only do they enjoy the fact they've had a nice deep response, they like the fact that they actually go on a drug holiday.
Absolutely.
The fact that many of them are off treatment. One of my patients I saw recently, he's like, Doc, I have known you, you've been taking care of me for a decade.
So this
is the first time I'm off everything, and they love it.
This is the same for my patients that have received CAR-T, because most patients are at late advanced stage of the disease, and they've been coming to the hospital every week or every other week for maybe 5, 6, 7 years.
And so
the first time that they have holidays after a treatment, and in fact, most of them in complete response.
So
despite the fact they love seeing us,
absolutely,
they're happy to not be there.
They appreciate very much this progression-free survival, although they recognize that sometimes the PFS is not very long like right now, but they appreciate a lot of this progression-free survival because, as you mentioned, they are for holidays of treatment.
So I think that maybe we're suffering from this idea that we're perhaps expecting too much. You know, we thought maybe it would just be the treatment we needed to cure myeloma. But if you look at it, the benefit is probably 2 or 3 times more than we see with a new agent. We've had all these new agents approved recently with response rates and benefit, which is not nearly approaching this benefit. So maybe we just need to look at it a little differently.
Correct, and part of it is I think, you know, we've been comparing to some of the lymphoma and leukemia situations, which are really different diseases.
Yeah.
You know, adolescent or you know, ALL is a different disease than multiple myeloma, and that's a very much more uniform population. Their T cells are not nearly as exhausted as myeloma patients' T cells are, and so it's different. But you're right, even when there was some skepticism seeing 10, 11, 12 months of PFS, that's still so much better than, honestly, as we know, their life expectancy after that many therapies is perhaps sadly only 3 or 4 months.
Absolutely.
So to be able to put someone in remission for the better part of a year, over a year, is significant. I agree.
Absolutely, and I've had this exact same reaction that you described from patients. They're just so pleased to be not coming in for treatment and feeling good and in a very solid remission. It is actually amazing.
Because one of the trends of the last few years, I think, is that, you know, because we're using more intensive treatments, as we've gone from doublets to triplets, maybe to quadruplets, as we've seen the benefit of maintenance therapy, many myeloma patients, even many listening tonight, are going to think, I'm just going to be on treatment for the rest of my life.
Right.
Yeah.
But we hope that these strategies of MRD negativity, of CAR T-cell therapy, of these newer agents, have the benefit of being able to take patients off treatment.
Absolutely.
As I joke and say, my favorite drug, nothing,
Nothing.
right?
Absolutely.
Patients are very compliant. Patients, the cost is really good. And the side effect profile is impressive.
Perfect.
You know, but it would be really nice if we can draw that for many, provide that for many of our patients.
So we just have a few moments left. So there's some other drugs that were presented at this meeting, like melflufen, for example, where they have some quite strong response data and the like, and seems to be reasonably well tolerated. Well, what do you think about this agent moving forward?
Yeah, melflufen is a new agent. I would say that it's a new alkylator. Maybe this is not the correct way. Just this an alkylator targeting aminopeptidase that are overexpressed on the plasma cell. So my idea is that at the end is a more targeted therapy, and the concentration of alkylator within the plasma cell is higher than when we use the conventional melphalan. Melflufen is effective, and I have a quite high number of patients treated with melflufen. Late advanced stage of the disease, even refractory to pomalidomide, refractory to daratumumab.
So this is important.
And they respond. Approximately 1/3 of the patients respond. The median duration of response is approximately 4 or 5 months. And we've seen a significant activity in some patients with extramedullary disease. What
really
is
important.
relevant, because sometimes we don't know how to manage patients at late advanced stage of the disease with extramedullary disease. I've seen how the plasmacytomas dramatically disappear with just one cycle.
Right. So this is important. Yes.
It's an alkylator-like drug, and of course we have to take care also about the myelosuppression, especially the thrombocytopenia, because it's severe in many patients, and it's reversible, but sometimes we have to wait for some weeks or even months to be recovered, as well as the asthenia, not many gastrointestinal toxicity, but well, definitely the clinical development plan is based on the combination of melflufen with safe drugs like bortezomib or daratumumab, and we will see what happens.
Okay, very,
and
very
I'm
good.
quite interested in the data you showed with the iberdomide, you know, the cell modification agents. I think there, you know, it was very conveniently taken. You know, the patients that I had on the study were, you know, very, it was not a very difficult thing to take, not dissimilar to the days of taking pomalidomide for them, many would say. And we saw, I think, quite an impressive response rate from it. And there are even next generation of those cell mods coming that seem to be at least early work in the lab.
At least one
seem
or
to be
two,
particularly
impressive.
impressive. And then, of course, probably the next approved drug potentially for multiple myeloma is going to be isatuximab,
Yes,
which
of
will be
course.
another CD38 antibody, very similar in many respects to daratumumab, will likely be approved in combination with pomalidomide, which you know, is an
It's
important
important,
arena
very
in that
important.
later relapse that you've
Absolutely,
described.
absolutely.
Part of the challenge will be a lot of those patients have already seen both Dara and POM, so we'll have to figure out exactly how that works, but that could definitely be a good option for our patients in the near future, especially with later relapse.
Absolutely. Well, I think that we've really covered the waterfront from smoldering to active with all kinds of options. And so I really hope that this has been a very, very helpful and interesting presentation for all of you watching tonight. And as we close out, I would like to thank you for watching. And then once more, I would just like to thank you all for supporting us, including our sponsors again, Amgen, Takeda, and Janssen Oncology. So thanks to my guests for this evening, Mary V. Mateos and Joe Mikhael.
Thanks, Brian.
Thank you.